All right, so let's look at step 2. So if you cannot make a specific diagnosis based on what we have said so far, step 1, now you need to rule out melanoma. Now, there's some easy things you could say. You could leave the room right now, say, I had enough, I'm end of the rope, right? If you haven't made a diagnosis yet, you biopsy to rule out melanoma without having to know anything more. You could do that, right? Your specificity is not going to be so good. Your sensitivity for melanoma diagnosis will be okay. So you'll be doing a lot of biopsies, but you'll catch your melanomas. So let's go a little bit deeper into improving specificity. So the first thing is you now enter a realm of melanocytic neoplasms where even the benign melanocytic neoplasms become problematic. And without context, it would be impossible really to know what to do. What are those? So number 1, homogeneous tan to pink. Very, very common in type 1 and 2 skin. Extremely uncommon in type 3 skin and higher. The peripheral globules, but now you have multiple peripheral globules. We call them tiered, one on top of the other, or where the center doesn't have a network, either one. 3, the classic starburst pattern, right, which Sheila showed this morning. And then you have the multi-component pattern, which is your sort of more your moderate to severe dysplastic nevi. Now, context here becomes critical. So you have, skin type, age, whether it's an outlier lesion, whether the patient has the atypical mole syndrome, et cetera, all are features, all factors that will play into what you will do with those lesions. So just the morphology alone is not enough to tell you what the lesion is. So this homogeneous lesion, little tan, pink lesion, right? In a type 1 and 2 skin individual, that is the most common Nevis pattern that they will manifest, okay? But they will also have more than one. So they have multiple lesions with the same morphology. This is a very uncommon pattern once you get to type 3 skin or higher. So the skin type and the other lesions on that individual, whether they have the same pattern or not, will dictate what you do with those lesions. And another example of one has no structure. It's just tan, end of story, or pink, right? So if that was seen on my skin, you'd be cutting it out to rule out amelanotic melanoma. But in a redhead, right, that's the most common pattern. And in fact, if you look at the other nevi, many of them will have the same morphology, right? So comparing to other nevi in the individual and skin type is going to dictate what you do with such a lesion. In terms of the starburst pattern, these all are in some variant of starburst, yeah? This peripheral globular pattern that we spoke about, benign, is in fact a starburst pattern, but it happens to be one that we now know is totally benign and we can exclude. But if you have the peripheral globules but not network, that's a totally different story. Those lesions and the ones that have multiple tiers of globules, and those that have a classic starburst pattern with streaks and pseudopods, those represent spitzoid neoplasms. And here, everything that Sheila said this morning holds true, right? So if it's somebody less than 12 years old, all 3 of these patterns are considered okay. You can leave them alone, send the patient home. Obviously, caveats of what the parents want to do and so forth, so on. But they're benign lesions. However, if you have somebody over the age of 12, and obviously the older it becomes more concerning, there is a probability that a melanoma could masquerade itself as one of these. And we have examples all over of melanomas that look like this, this, and this in individuals in their 40s, 50s, 60s, 70s, okay? So in young individuals, these are acceptable benign patterns. In somebody older, you would, the same exact pattern, exactly the same, you would actually need to biopsy to rule out melanoma. Now, in the Starburst pattern, whether it consists of globules or whether it consists of streaks, it actually represents the radial growth phase of a tumor. In the one that has network with peripheral globules, it's the radial growth phase of a Clark's nevus. And as I said, from inception to senescence takes about 5 years. And if you were to follow them over the course of time, this is what you would see. The lesion would become symmetrically larger, the globules will become smaller and sparser, and eventually when the nevus enters senescence, it will either be a reticular nevus or a homogeneous nevus, but there will be no more globules. That's the end of the life of that nevus, and it will remain in senescence unless something occurs later that causes involution, but it won't continue to grow. And obviously we use that in our screening, right? Because if you have a person that has stable nevi, right, then a senescent nevus that at some point in time breaks through senescence, it becomes concerning. That's the whole idea of total body photography. You get total body photography, follow your high-risk patients so that when a nevus that should be in senescence and remain in senescence or should be involuting, on the other hand, is evolving, those are lesions that are likely melanoma, right? So we use that to our advantage. And in the classic Starburst nevus, the same. So here is a very early form, and then if you were to follow it over the course of time, it will become symmetrically larger. These are the Reed's nevi, the streaks and pseudopods, thinner and sparser, and eventually when that lesion enters senescence, you will have a homogeneous brown nevus with a central bluish hue. That's the Spitz-Reed's nevus, right? The fascicles that are going into the dermis, the banana-shaped fascicles, right? That deeper pigmentation that gives you the bluish hue. That's your classic end of the life of a Spitz nevus of the Reed's type. And then the only other thing this will do, maybe, is involute over time, right? But after senescence, it's not going to evolve again. If it does, it becomes concerning. Okay. So that's your Starburst. Some more examples of the Starburst pattern, Reed's nevi. And now we talk a little bit about the Starburst pattern, which consists of the peripheral globules. And here's to make the point that peripheral globules with network in the middle, that's benign. Okay? That's the one that we have excluded, we no longer biopsy. Here's peripheral globules, but what's in the middle? Not network. All bets are off. 0.7 millimeter melanoma, Clark's nevus. Okay? So peripheral globules are benign, but only if there's network in the middle. That's the reason for showing that. And here's some more of these tiered globules. The one all the way on the left is the classic example of a tiered globular nevus. Again, spitzoid morphology. And then your Reed's nevus with streaks, and your Reed's nevus with pseudopods, but all of them are within the grouping of Starburst pattern. And then you have the two-component pattern, which self-explanatory, right? This is a pattern that is seen in individuals that have the atypical mole syndrome. And here's another example. And add to that one that has multiple structures. Here's blotches, there's dots, there's network. And this pattern, again, is not uncommon in somebody that has the atypical mole syndrome, meaning it's an individual that has over 50 nevi with increased variability in size, shape, and color of the nevi. And when you see one of these, if you look at the other nevi, many of the other nevi will have a similar morphology. That's the context that this is acceptable in. If you take this as an isolated lesion here, it becomes concerning. So that's the context again that plays in, right? So those are your context, the nevi that require context to know what you're going to do with them. In these cases of the atypical mole syndrome patients, we would never ignore them. We'd say they're benign, but we would monitor them. We would never say go home, goodbye, right? Okay, so now you could say, okay, I heard enough. I know step one, I know the nevi that require context, and everything else I'm going to remove. You could do that. right? But you can go one step further and say, okay, what are the features of melanoma so that I can really know if it's a melanoma right from the get-go? And so for those, we now talk about what's known as the melanoma-specific structures. Now, one of the key features of most melanomas, and we'll talk about some exceptions in a moment, but most melanomas, you know that they're melanomas immediately. So you look at them clinically, you already suspect melanoma, and you put your scope on and it's just ugly. It's ugly because they're disorganized, chaotic, they're structures and colors and all distributed in some bizarre random fashion, right? So they're just unease, disorganized. So you instantaneously know, and then you start to see the features and say, well, now I see this and I see this and this, but you already know it's a melanoma right from that moment that you put your scope on because it's disorganized. Now, there are a few melanomas that actually appear organized. We'll talk about them at the end. But what is important to know about these melanomas is that prior to dermoscopy, these were melanomas that were diagnosed only by chance. So things like, it's nothing, don't worry about it. No, doc, I need this off, I don't like it. Okay, I'll do you a favor and remove it, right? And then the pathology comes back and you're horrified that it's a melanoma, and now how are you going to explain this to the patient, right? That scenario. So those melanomas that were, where we were so confident that they were benign, they actually don't occur in the hands of dermoscopists anymore, because they don't really exist. And those sort of more symmetric appearing melanomas, such as desmoplastic, nodular, nevoid, amelanotic, right? They all have classic features on dermoscopy that will help you to know that they're melanomas, and we'll talk about those at the end. Okay, so what are the features of most melanomas? Most melanomas have at least one of these features. They're all on your card. These are known as melanoma-specific structures. In the card, in the old card, we had these lines and these blotches, but I put a question mark on it because it was based on one study and it hasn't been reproduced. And in my clinic, this is not true. It does not hold water. And so I have elected to exclude them, but you will see them in the literature, but we're not going to talk about them here. Now, melanoma-specific means that there's a high specificity for the diagnosis of melanoma, and that carries with it a high odds ratio that the lesion in question is a melanoma. It doesn't mean that a Nevis cannot have one of these features, but it is more likely to be a melanoma if you see that feature than a Nevis. And the more features you have of these melanoma-specific structures, the more likely the lesion that you're looking at is in fact a melanoma. And these are the melanoma-specific structures. Now, if you notice that in these structures, there's some that have a break-off into typical, atypical, regular, irregular, typical, atypical, and others that don't. They just have one box. The reason for that is that if there is only one box, you basically have to biopsy, okay? Because there is no way to distinguish between a benign and malignant angulated lines or shiny white lines, crystalline structures. You can't use them to distinguish between. So if they're present, you're basically committed to biopsy. Whereas the others, there are qualitative differences that can still be used to differentiate benign from malignant. And obviously, we're talking about Nevis from melanoma. So let's look at network. The pigment network is due to the reedy ridge pattern of the skin. There's no more pigment per unit area over the reedy ridge than over the suprapapillary plate. The suprapapillary plate, that's your hole. The reedy ridge, that's the line of the network. Therefore, if you see a network in a melanoma, you know you're dealing with superficial spreading type melanoma. And think about this a little further. If it's a superficial spreading melanoma and it's starting to disrupt this reedy ridge pattern, it's going to lead to some kind of chaos to the network, irregular network. Right? So the difference between a Nevis and a melanoma when it comes to superficial spreading melanoma, when we look at network, is whether the network is regular or irregular, okay? Regular network, minimal variation in the color of the lines and the thickness of the lines and the distribution of the lines, and they're pretty contiguous. Whereas atypical network, increased variability in color, thickness, they get broken up into fragments within the lesion, right? It's instantaneous gestalt recognition, there's something not right. So uniform and a non-uniform network. Uniform, non-uniform. So the definition of an atypical network depends on the lesion that it's in. You see, if the entire lesion was made out of this and all of this was this, it would be regular. It's irregular because the quality of the network here and here and here and here is different, and that it's kind of haphazard the way it's distributed as opposed to be a more homogeneous distribution of the network, okay? Similarly here, the two lesions on the left-hand side are benign nevi with a normal network. The same quality of network throughout, the same quality of network throughout. If I take a little piece of this network and I put it there, if I take a little piece of this and put it there, it becomes atypical. So again, it's lesion-centric. The definition of typical versus atypical is lesion-centric. This is atypical network because of the distribution of the network, and the quality of the network is different in different areas. The sizes of the holes of the network differs in those different areas. Angulated lines. Angulated lines are basically brownish but usually grayish lines that meet at angles that can create a zigzag-like pattern, and the zigzags can coalesce to create polygons, the most common polygon being a rhomboid. Okay, so here is your classic angulated lines that are coalescing, they're gray, into these polygons. And this is basically melanoma until proven otherwise. When you see angulated lines, it indicates melanoma on sun-damaged skin of the lentigo maligna type. That's what it corresponds to. Histologically, what you see is blunting of the DE junction with melanophages and pagetoid cells. So confluent junctional melanocytes, flattening of the DE junction, pagetoid cells, and melanophages all together that creates the angulated line. Those are the characteristic features of lentigo maligna melanoma. Streaks. Now, much of this is repetition because you already heard about this. Streaks, right? So what's the difference between regular and irregular? Regular streaks is when they're around the entire perimeter of a Reed's Nevis. That's the Starburst pattern. So around the entire perimeter of Reed's, if it's not around the entire perimeter or of different types, so you have lines and pseudopods and dots, then it becomes irregular. So here is a lesion that has this straight line, the radial streaming, and one with a bulbous ending that's a pseudopod. They both are under the term streaks because both of them represent the same entity on the histopathology, which is confluent junctional nests of melanocytes. It is the horizontal growth phase of superficial spreading melanoma or the horizontal growth phase of a Reed's Nevis. Okay? So here's a Reed's Nevis around the entire perimeter. That's regular. Irregular, where you just have focal areas but not around the entire perimeter. Now, with that said, remember, this is one of those lesions that other factors come into play. While it's regular, if this occurred in an 80-year-old, you're still going to remove it. If this was in a 5-year-old, you would leave it alone, right? So we're talking about in the older individuals, right, then they'd really be both irregular, but suffice to say that that's the definition right now, regular, irregular. Okay, next, negative network. This is a little bit of a difficult one for many people to grasp. So what is a negative network? I like to look at it not on the negative, but on the positive end of the spectrum. So what do I mean by that? So there's brown structures. The brown structures, instead of being round to oval in shape, are elongated and curvilinear. Just imagine that you had the silly putty, and it was a glob, a round structure. And then you take the silly putty and you stretch it, okay? That to me is these brown structures. And the reason that you see them is because there's relative hypopigmentation adjacent to it. That's why you see the brown. The original definition was it's a negative network because this white line is kind of meandering around this in a serpiginous fashion. So think of this as a brown canvas, and then white lines were drawn through it. That's one way of looking at it. I like to look at it the other way, okay? And so here's an example of a lesion with a negative network. Notice that the brown structures are kind of a little bit elongated and curvilinear, right? These are not classic round to oval globules. And the reason that you see them is because of the hypopigmentation adjacent to it. And it's present throughout the lesion. That's your negative network. But that is probably the most blatant negative network you will ever see. Most of the time, a negative network that you will see is not going to look like this, it's going to look like this. But if you look at the top here, the definition still holds true. Look at the brown structures. They're not round to oval. They're elongated, they're curvilinear. And again, the reason that you see them is because there's relative hyperpigmentation adjacent to them. That's a negative network. And what do they correspond to? It corresponds to one of two things under histology. Either it is large, dense nests of melanocytes that are in the papillary dermis, causing the reedy ridges to be squished and elongated, or it's due to bridging of adjacent reedy ridges. Either one can give you the appearance of what looks like a negative network. Now, where can you see a negative network? You'll see the same theme coming through again, spits and melanoma. But there is no way to actually differentiate between spits and melanoma based on the quality of the negative network. This is a negative network. Look at the brown structures, elongated, right? They're light brown, tan in color, and the reason that you're seeing them is because there's hypopigmentation meandering around them. Here, same, look at the brown structures, elongated, curvilinear, with relative hypopigmentation around. That's the most common way a negative network will appear. But it's important to be able to appreciate that because it's when you see it, it's a very powerful predictor of melanoma. Okay? Now, in the old days, we used to think that if a negative network was present throughout the entire lesion, it speaks in favor of a spits. And if it was present only focally, it speaks in favor of melanoma. But multiple studies have shown that that's not true. Right? That the overlap is significant enough that you can see a negative network throughout the lesion, but it could be a melanoma, and you can, in this case, this was a melanoma, but this is also a melanoma here with this focal. So you can't actually use that to distinguish between a spits and a melanoma. And so they showed again here that the overlap between melanoma and spits is high enough that you can use that to distinguish between the two. And then this was the final paper that basically said that if you see a negative network, you're basically forced to biopsy to rule out melanoma because the quality of the negative network cannot be used to differentiate between a spits and a melanoma. So negative network focally present at the top in this melanoma. What is by the way, the negative network, what it corresponds to also in terms of diagnosis in melanoma, for whatever reason we don't know, it corresponds to melanoma arising in a nevus. So when you see a melanoma with a negative network, very often there will be nevus cells, right? Okay, crystalline structures, that's the old term. The new term is shiny white lines that you see with polarized light. We have already encountered shiny white structures with polarized light already. We saw the rosettes, right, in our keratinizing tumors. We saw the blotches and strands in our basal cell carcinoma. Now we have a third structure, which are these little white lines that are often oriented parallel and orthogonal to each other. And that's the structure that we're talking about, so these shiny white lines. So here's a melanoma. On the left-hand side, you see it with standard light dermoscopy. On the right-hand side, it's with polarized light dermoscopy. The shiny white lines can only be seen with polarized light, and they're very clearly shown here. Most of them parallel, but some of them are running at 90 degrees, so orthogonal to each other. Here's a hypomelanotic melanoma, but again, under polarized light, all you see are shiny white lines throughout the lesion, both parallel and orthogonal to each other. What do they correspond to? They correspond to altered stroma, and in fact, it corresponds to newly laid down collagen, okay? And it turns out that very early melanoma progression requires collagen scaffolding, new collagen to be laid down for melanoma to grow, and hence the presence of crystalline usually means that it's an invasive melanoma, or at least a melanoma on its way to become an invasive melanoma. And it correlates also with thicker melanomas. Now, where else can you see these structures? Once again, we come back to Spitz and Reed's nevi. Spitz nevis with these shiny white lines, Reed's nevis with shiny white lines, okay? But again, the presence of shiny white lines, once they're there, you actually cannot use them to differentiate one from the other, right? You're kind of stuck in, with that as your differential. In a prospective arm of the study, when we looked at almost 10,000 dysplastic nevi, really only one manifested crystalline structures of these shiny white lines. In our prospectively diagnosed Spitz, we actually only had 3, but all 3 Spitz nevi had. Since we did this study, we found that almost all Spitz nevi have it. And then for an interesting observation that in our prospectively diagnosed melanomas during the prospective part of the study, that almost all of our invasive melanomas revealed it, and none of our in situ melanomas revealed it, and we found that curious. So we took that a step further and retrospectively went back and looked at all of the melanomas we had, and basically it bore true that 41% of our invasive melanomas had the structure. Only 17% of in situ melanomas had the structure. Now, I'm not going to say much except that in a very warped way, we went and just looked at these in situ melanomas, okay, to see if we were to cut more into the block, right, would we find invasion? And in fact, in about 40% of the lesions we found invasion, but small, 0.15, 0.2, right? And the reason that we haven't done anything with this data is because I don't know what that means. I would have to take a whole bunch of in situ melanomas that don't have the structure and do the exact same thing on them to find out how many of them have microinvasion. You follow what I mean? Right? But it's just for me, a thought whether this actually is a feature of invasion. Anyway, when we then looked at the invasive melanomas, we also found that those melanomas with the structure were thicker, they had a mean thickness thicker than those without. So there was another clue to that. Now, that was it for the dermoscopy end, and everything else is the exciting part is occurring on the basic science end. But clearly we know that when melanoma grows, it's not growing by itself. It's communicating with fibroblasts and keratinocytes, and there's a lot of things going on. And there is something that occurs where you have stromal induction, which is the melanoma cells communicating with fibroblasts to lay down collagen, which then allows the melanoma to grow into the dermis. And when stromal induction occurs, so does new angiogenesis. They go together, right? So you get new angiogenesis and stromal induction occurring together. And it turns out that people have started to look at this phase of of melanoma progression and have found that it's collagen 17 that is being laid down for this melanoma to grow. So it is highly likely that many of the crystalline structure, these shiny white lines that we are seeing, are actually this collagen 17 being laid down with this communication between the melanocytes and the fibroblasts. Now, it was the first dermoscopic structure that actually gave us some information about prognosis. We said, well, it predicts an invasive melanoma, and if it's an invasive melanoma, it predicts a thicker melanoma. And it was the first structure that then said, well, you know, there may be other clues as well, and it's beyond the scope of this talk, but there are now multiple structures that have been identified that actually carry with it prognostic information about the specific tumor. Okay? All right, blotches. Typical and atypical. You already heard about the typical blotch. What's a typical blotch? It's the one that occurs, one blotch, in an otherwise reticular nevus. That was the first thing we spoke about when we started, right? Step one of the two-step algorithm. One of the benign nevus patterns was the peripheral network with central hyperpigmentation. That is the only acceptable benign blotch. If you have more than one blotch, or if you have an off-center blotch, then it becomes concerning for melanoma. So what is a blotch? A blotch is an area of so much pigmentation that it obscures your ability to see anything else. Similar to that idea of keratin. If you have keratin, you can't see below. So here you have so much pigment you can't see below. So there is enough pigment in all layers of the skin that you can't actually see anything on the dermoscopy. And so again, normal, regular blotch is the one that I described in a nevus. And this blotch, if you were to take tape and pull it, stick it on the lesion and pull it off, and do that a couple of times, you will often remove that blotch. It'll come off. In fact, what it represents is melanin that has been put up into the stratum corneum, right? As the nevus is putting the melanin into the keratinocytes, as the keratinocytes are growing up into the skin, they get into the corneal layer. Eventually, they go off into the environment, and so that is what they represent. An irregular blotch is more than one blotch or a blotch that's off-center. Either one is considered atypical. And the other thing that's important is that a blotch that is atypical cannot be tape stripped off. You see this in the nevus, this is just in the nevus, this is just in the stratum corneum, so when you do the tape stripping, this comes off, but this has to do with pigmentation below the stratum corneum, so you can't tape strip it off. So there are differences on this mechanical level that you can also tell the difference between regular and irregular. So typical blotch, one in an otherwise normal network pattern nevus, atypical being an off-center blotch. Okay? Dots, typical and atypical. So dots basically the size of the pointer, pinpoint, and the color of dots are usually brown or black in color. Okay, those in a melanocytic neoplasm. The difference between regular and irregular has to do with placement and their association with network. So a normal dot is a dot that occurs in a reticular nevus, and only in a reticular nevus. And the reticulation is normal. So it's almost as if the presence of the typical network has to be the first thing. And then the dots can be in the middle, on the line of the network, or in the whole of the network. Those are benign. Any other manifestation of dots becomes irregular. So in the middle of an otherwise normal network pattern nevus is considered normal. Here, no network, dots become atypical. So in the middle is normal. If you see the network lines and you see the dot right on top of the network lines, that is also considered typical. And then here is the lesion. If you look close up, you see the dots right on top of the network line. Normal, what do they represent? They represent a small cluster of nevus cells at the tip of the reedy ridge. Okay? And that projects onto the network as a little brown dot. That is the hallmark of a benign nevus. If this nest starts to move up along the reedy ridge onto the suprapapillary plate, you're getting into dysplastic into melanoma. But when they're present only at the tip of the reedy ridge, it's a feature of a nevus. And that's shown here as well. So the little cluster of nevus cells, and it comes right up to the projected on the network line. And then the third, is that the dot is smack in the whole of the network. Yeah? So you see it right in the whole of the network. So those are your three benign patterns, and what they represent is a small cluster of nevus cells in the papillary dermis that projects as a small dot in the whole of the network. So those are your three benign dots. Yeah? Any other way that you see a dot becomes atypical. It's as simple as that. So no network, off-center becomes an irregular dot. These are obviously irregular dots, right? So there's no network, it's not associated with network, it's not on the network lines. So although there are lots of these dots here, I mean, there's a little bit of network, but they're not on the network line, they're off the network line, become irregular, and would be concerning for melanoma, and that was indeed a melanoma. Globules. Globules now are larger than dots. They also come as a regular and irregular, okay? Typical and atypical. So what are your globules in terms of color? Usually brown we're talking about, okay? Brown, and the globules are oval to round in their morphology. Once you get into black globules, you're getting into the realm of melanoma. If you get blue globules, on rare occasions you can see them in congenital nevi, but they're not very common. Just as a little caveat, there are also white globules that are seen in balloon cell nevi, but beyond the scope of the time we have to talk about that. But what's the difference between regular and irregular? Regular, again, the same color, size, shape throughout the lesion, okay? So the quality of the globules, and irregular globules become globules that are of different sizes, shapes, and color. In addition, there are three forms of patterns of globules that are considered benign, and all three of them you already know. And what are those? So globules throughout the lesion was one of the benign patterns of nevi we spoke about, both the cobblestone and the globular. Two, at the periphery with network in the middle, that was also spoken in that first line, step 1 algorithm, or centrally located with network around, which was another one of the benign Nevis patterns. Those are the only three ways in those three patterns that globules are considered benign. Any other manifestation of globules, right, off here becomes concerning. Okay, so what are the normal globules? Globules are the same type throughout the entire lesion, centrally located with network around, or the perimeter of the lesion has globules. But you already knew all that. Those are the only ways those globules are normal. Any other way becomes atypical. Globules of different sizes, shapes, and colors becomes concerning, and globules that are distributed more chaotically within the lesion become concerning. For melanoma, blue-white veil. We're getting to the end. Blue-white veil. It's important that when we talk about this structure that you run your hand across it, because what we're talking about when we talk about a blue-white veil, it's a palpable portion of a lesion. When you run your hand across it, you'll feel substance. You will see when we talk about regression structures, you can also see blue-white color, but it's over flat, right? Non-palpable. So blue-white veil, by definition, means that it's an area that's palpable. Basically, it's a confluence of blue-white color within the lesion. There is one benign pattern. So anyway, here's this classic blue-white veil, okay? And what it corresponds to is deep-seated melanin melanocytes together with compact orthokeratosis. The deep-seated melanocytes gives you the blue color, the compact orthokeratosis gives you the white color, and the combination is what gives you the blue-white veil, okay? And here is a Reed's Nevis that has a blue-white veil. And now just think about when I was talking about biopsies and that you can predict histology, all of the information you can gather from this lesion. So this is standard light on the left, polarized light on the right, okay? So I can tell you that the pathologist will see radial growth phase, some kind of a radial growth phase because you see streaks. 2, I see a blue-white veil here, but it disappears in the polarized light. What that means is that the blue-white veil is due to orthokeratosis. Polarized light looks beyond. It doesn't see the top layer of the skin. It sees beyond. So it doesn't see the veil. So since the white is gone, I know that's orthokeratosis. So I can predict the pathologist will see orthokeratosis on the biopsy. Next is I know that there is something occurring in the stroma as well. So this is going to have something beyond just at the D junction. right? So yes, there'll be confluent junctional nests of melanocytes, the radial growth phase, but in addition, there'll be something that's occurring in the dermis as well. So you can see a lot of information that you can gather when you look at polarized, non-polarized light and you put the pieces together. Now, in terms of regular, irregular, the only regular one is homogeneous blue throughout in the blue nevus, with the caveat that in a patient with a previous melanoma and epidermotropic metastasis can have the exact same morphology, right? In melanoma, on the other hand, the blue-white veil tends to be a little bit heterogeneous in its hues and a little bit more irregular distributed. So blue nevus, melanoma, blue-white veil, but the quality is completely different, kind of more homogeneous in a blue nevus, more heterogeneous in a melanoma. Okay, regression structures. Now, regression structures consist of two things that can occur together or independent of each other. So, it consists of granularity, melanophages in the dermis, and scar-like depigmentation, fibrosis. They usually occur together, but they can also occur separate from each other. Now, in a nevus, you're allowed to see regression, but in a nevus, the only regression that is permitted is granularity, not the scar-like regression, only granularity. And that granularity has to encompass less than 10% of the surface area of the nevus. That is okay in a nevus. If you see more than 10% granularity and the minute you see scar-like depigmentation, then it becomes concerning for melanoma. So let's take a look at, well, schematics. Here's the scar-like depigmentation granularity. And when you have so many melanophages, imagine that there's like millions and millions of melanophages. They can actually coalesce into a blue-white structure that is reminiscent of the blue-white veil we just talked about, but the difference is this is flat as opposed to the previous one, which was raised. Okay, so let's talk about granularity. So here you can see this grayish granularity throughout. It corresponds to melanophages. There's a little bit of scar-like depigmentation as well. And basically, again, just melanophages in the dermis. And then this melanoma has scar-like depigmentation and granularity. There's also this kind of bluish haze here. That all represents regression. So scar-like depigmentation, granularity, scar-like depigmentation, granularity. And again, represents regression. And if there's so many melanophages, they can all come together into this blue-white veil-like area, but it's flat. But you can, at the edges, you can usually see that there's the fine granularity, scar-like depigmentation, and it just, then the melanophages get so much that it appears blue-white. And as I mentioned, in a nevus, you're allowed to have some regression, but only granularity encompassing less than 10% of the surface area of the otherwise benign appearing nevus. This melanoma has over 50% of its surface area, with granularity becomes concerning, obviously, for melanoma. Peripheral tan structureless areas. This is not a very common structure. It is actually only seen in superficial spreading type melanoma and lentigo maligna type melanoma. And basically, it's brown structureless areas at the periphery of the lesion, not within the center. This is the paper that it was first published in, and what they noticed is often at the periphery of superficial spreading melanoma, you would actually have this brown structureless areas. And when they looked at histologically what it corresponds to attenuation of the reedy ridges with pagetoid cells. And so think about this area of a network, right? So you have a network, and that was, when you look down, you see the network pattern, right? And there's pigment, so it's brown lines creating. Now imagine I take away the network and I make it flat, but you still have color. All of a sudden, the network is gone, and you just have homogeneous brown, right? And so what has been shown is that in superficial spreading melanoma, as it grows, it actually destroys the reedy ridges, right? And when the reedy ridges are destroyed, the network is no longer visible, and it becomes homogeneous tan, okay? And so, can you see homogeneous tan in nevi? Sure, but with those benign patterns we already spoke about. So peripheral network, central hypopigmentation. It's not depigmentation, it's hypopigmentation. But the minute you get to tan at the periphery, you got to be thinking melanoma. All right? Not very common, but if you see tan structureless at the periphery, think melanoma. In the center, it's acceptable. At the periphery, it's not. The melanoma has other features as well, including a negative network, right? So there's a negative network in here that helps you to know that this is melanoma, but it also has the tan structureless at the periphery. And this is just a schematic showing you that as the melanoma evolves, the superficial spreading melanoma, it destroys the radial ridges and flattens, and the D junction becomes flattened. If there's still pigment there, you will only see homogeneous tan pigment in those areas. There was an interesting study that was done a few years ago. The data actually makes more sense today than it did when we did the study. Basically, this was, we went to all the high-risk centers, and we said, have you ever taken a picture of a melanoma with dermoscopy, but you thought it was benign, and then you didn't do anything about it for at least 1 year, and when you removed it, it was a melanoma, but it was a melanoma from day one as well, right? And so, yes, we were able to collect a bunch of melanomas. We call those the slow-growing melanomas, so that at some point after a 1-year period of follow-up, they were eventually removed and were indeed melanomas. And then we wanted to find out that what was the change that occurred from that first image to the image at the time of the removal, which was at least a year later, right? And the most common change was the disappearance of network in being replaced with homogeneous tan, right? So it's this evolution of a superficial spreading melanoma. All right, and then the last is vessels. In terms of vessels, you kind of already know. There's only one vessel that I told you was benign, right? One vessel, and that is in a sessile mammillated lesion that looks like an intradermal nevus. And in those lesions, if you see vessels that have the shape of a comma, that's acceptable. Any other manifestation of vessels becomes concerning, and there's all bets are off. In a melanocytic lesion, you're almost, in a way, forced to biopsy. Vessels are very sensitive to pressure. They only need about 12 millimeters of mercury pressure to blanch them out. So if you press on it, they go away. If you use a gel, like an ultrasound gel, and then very lightly put your scope on it, you will see them. And obviously, if you use polarized light without contacting the skin, you can see them extremely well, and you can see the entire vascular blush much better here. It's all blanched out just by putting the scope on the skin. So be aware, to see vessels, ideally you want to use polarized non-contact dermoscopy. And your atypical vessels, basically dotted vessels and serpentine, in the old literature called linear irregular, now called serpentine. So dotted and serpentine vessels, and especially the combination of dotted and serpentine. So if you have both together, they become highly suggestive of melanoma, if not diagnostic of melanoma. That's known as the polymorphous vessel pattern. And the milky red globules we talked about when we spoke about angiomas, right? So obviously milky red globules are important because they're a feature of nodular melanoma, but these are the vessels that we're going to talk about, dotted and serpentine, and the combination of the two. Already mentioned the only benign vascular pattern, comma vessel and a sessile raised intradermal nevus, and then any other vessel pattern becomes concerning. If you look at the nodular melanoma on the right-hand side, you can see the entire lesion is pink in color, and then you see these very large dilated serpentine vessels in the melanoma. You can see them here and here and here. So not only are they large and dilated, they're also polymorphous. The diagnosis is melanoma. This is nothing else it could be except one other thing, and that's Merkel cell carcinoma. Merkel cell carcinoma has the exact same morphology as melanoma, as amelanotic nodular melanoma. Exactly the same. Can't tell them apart. So in this pattern becomes melanoma. Now, you can see vessels in dysplastic nevi. This happens to be a dysplastic nevus on the left that has dotted vessels, but once you see vessels, there's no way other than a biopsy to know exactly what's going on. On the right-hand side, it's a melanoma. It has little serpentine vessels and also lots of dotted vessels, but in addition, it has shiny white lines, right? And this, they occur together. Remember I told you before that when they have stromal induction, new angiogenesis occur together. So when in a melanoma, when you see shiny white lines, you almost always will also see vessels. They occur together in about 88 to 90%, right? When you see white structures, you'll also see vessels. If you want to learn more about vessels, This is the paper I'll refer you to, but the take home from it was that both the presence of dotted vessels and serpentine vessels are positive features for the diagnosis of melanoma, especially if they occur together. And that's what I'm going to show you here. So first, dotted vessels, lesion on the leg. Under standard light dermoscopy, putting it on with alcohol, putting it up against the skin, I see nothing. I take the pressure off and bingo, there they are, little dotted vessels. In addition, notice they're also early shiny white structures, right? Very early. They often occur together, but so there's a little serpentine vessel and dotted vessels, melanoma. Serpentine vessels, this is a melanoma arising in a dysplastic nevus. And so here, all the serpentine vessels, notice when I talked about the myth of the hair is only to differentiate intradermal nevus from basal cell. It was never intended to differentiate a melanoma from a nevus. This is a thick melanoma with hair. It means nothing, okay? So in this is an amelanotic 1.65 millimeter melanoma arising in a dysplastic nevus, and here are all the serpentine vessels that you can see under non-contact polarized light. And then you have the combination of the dotted and serpentine vessels. And so here's, again, the power of dermoscopy. So here's a lesion on the abdomen. This guy has had lots of basal cell carcinomas. My mind is basal cell carcinoma. The guy is dry, so this is a little bit of xerotic skin. So pink lesion, probably basal cell. I'm expecting to see arborizing vessels, maybe some shiny white blotches and strands, right? Now I put my scope on, but instead of seeing that, this is the picture I get, right? And total disconnect. Vessels, dotted and serpentine, right? If you see dotted and serpentine vessels, your differential diagnosis is melanoma, 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 and if you insist on having a fourth in the differential, it would still be melanoma. It is that powerful a predictor. If that's the only features you see, dotted and serpentine, that is the classic features of amelanotic melanoma. Okay, now in the last 10 minutes, I'm going to leave you with something very easy to take home, okay? So basically we went through the two-step algorithm, but that's not all, because we only covered sort of the glabrous skin, not a non-glabrous skin, not including the face. We didn't talk about mucous membranes. We didn't talk about palms and soles and nails, right? The anatomy of the face, the palms and soles, the nails, and mucous membranes is very different than the rest of our skin. And because of that anatomy, they have their own features, right? That another 2 hours, okay? So we covered everything else other than those so-called special sites. Now, what can you take home if you said, listen, I want to start using dermoscopy today, okay? So how can I simplify it where my goal is just to find cancer, but I don't really want to make a precise diagnosis. I don't care if it's a basal cell, squamous cell, or melanoma. I just want to know, should I biopsy the lesion or not, with a reasonable specificity. I don't mean cutting off everything. So with a reasonable specificity. So are there simpler methods of detecting skin cancer? And multiple people have attempted to do that, and these are called triage algorithms. These are a bunch of the triage algorithms that have been published before. They all have their pluses and minuses, but the problem is that each one is specific to a very specific group of lesions. Pigmented lesions, only lesions with blue-black color. So they don't encompass everything, okay? So the question was, can you actually take all of these and amalgamate them into one that encompasses everything but is easy to use? Now, together with that, there's a couple of new pieces of information that these previous algorithms weren't privy to, and they were not included. Number one is the diagnosis of the run-of-the-mill seborrheic keratosis, angioma, dermatofibroma is actually quite easy. It is so easy, and you make it with so much confidence that why would you ever want to muddle it up into an algorithm? And we have now done 3 studies to show that this is very easily learned, and if you are confident that's what the case is, they are excluded. If you're not, they will enter the algorithm. Okay, so only those that you're confident are one of these three do not get into the algorithm. The other thing that we came to understand, and the first insight was in this study, where imagine we all took an exam right now, and I gave you, and I showed you an image, and then I asked you to put a checkbox of every structure you see. Do you see a network? Yes, no. Do you see streaks? Yes, no. Do you see, right? And we want to see how much in agreement we are. It turns out that for any specific structure, we have very, very, very poor agreement. Okay? However, the most subjective of features, we have very good agreement. And what is that subjective feature? It has to do with this idea of architectural disorder versus order, organized versus disorganized. Our brain can instantaneously recognize if the lesion, the colors and the structures that are distributed in the lesion make sense, they're organized, or they're not. And the previous algorithms weren't privy to this information. So now I want you to take a look at this slide, the next slide, and I want you to tell me if it's organized or disorganized. Organized. It's not symmetric, but it's organized, and that's the difference. We're not talking symmetry here. We're talking about some natural order that our brains intuitively know is a natural order. How about this one? Disorganized, right? You can recognize, you don't actually have to identify anything that's on the table, the pen, the paper, the coffee cup. You don't have to actually identify the structures by knowing that it's organized and disorganized. And this is the same issue when it comes to looking at lesions, that you can instantaneously recognize when a lesion is organized and disorganized. That's organized and that's disorganized. The silhouette of the lesions are symmetric, right? But the content under dermoscopy, that's a Nevis, peripheral network central hypopigmentation, and that is a no. Blue-gray ovoid globules and nests, right? That is a pigmented basal cell carcinoma, right? So disorganized. But for this algorithm, it doesn't matter, because just the fact that it's disorganized, you're going to biopsy. Whether it's a melanoma or basal cell doesn't matter in this algorithm. Okay, so take all of that information, amalgamate it into one, and you get the TADA, right? TADA algorithm, triage amalgamated dermoscopy algorithm. And what does it say? It says that if you know it's a seborrheic keratosis both on clinical and dermoscopy, that these are the features you see and nothing else, only those, or if it's a dermatofibroma that feels like a dermatofibroma and dimples that has only these structures and nothing else, and if it's an angioma that looks exactly like an angioma with the septate that separate, that those lesions you can ignore and send the patient home. If it's not an unequivocal a sepcare angioma dermatofibroma, then look at whether the lesion is organized or disorganized. If it's disorganized, biopsy it, end of story. So far, easy, yeah? So disorganized under dermoscopy means not the silhouette, but the content. This is disorganized, this is organized. The top lesion is organized, the bottom is disorganized. The pizza on the left is organized, the pizza on the right is disorganized. The nevus on the left is organized, the melanoma on the right is disorganized. The basal cell is disorganized, the squamous cell is disorganized, the melanoma is disorganized. If it's disorganized, it gets removed. Now, what if it's organized? Then what? And here is where the problem arises. Here is where all of those melanomas that gave us nightmares before enter. However, they have something in common, okay? And the common is only what's in this box. So that's the only thing you have to know. If it's organized, if it's disorganized, you biopsy. If it's organized, and if it has one of these features, you biopsy. And if it doesn't, you send the patient home. What are those features? Now, these are the types of melanomas that are the difficult to diagnose melanomas, from nodular, desmoplastic, nevoid, amelanotic, verrucous, spitzoid. They all fall into that group, okay? They appear organized. But here are the features. Number one, anything that has a starburst pattern, even if it's organized, for all the reasons we already mentioned, right? So organized starburst pattern comes up because it could be a spitzoid melanoma. A lesion that has a blue-black color. So a nodule with a blue-black color. Nodular melanoma usually has a blue-black color. In addition, epidermotropic metastasis. Remember I said the exception to the blue Nevis rule? This is the epidermotropic metastasis. Right? So blue-black color. Gray color we added because gray is the most sensitive feature of lentigo maligna. In fact, about 97 or plus % of lentigo malignas will have gray color. So since we want to encompass all melanomas, put in gray as well. So gray color for melanoma. Shiny white for all the reasons we mentioned. Shiny white blotches and strands, shiny white circles in squamous cell, shiny white lines in melanoma. If you see shiny white, it becomes concerning. Negative network, we talked about that, spitzoid melanoma, and vessels, right? Add to that ulceration as well, and you have the whole gamut. So what are the features that you really need to know? If you have a organized lesion and you see a starburst or a negative network or blue, black, or gray color, white structures, vessels, and ulceration. If you see that, you biopsy. What are you left with if you didn't see those features? It turns out that what you're left with are these nevi, which are all the nevi that we spoke about already, the benign pattern nevi, okay? How well did the TADA algorithm do compared to the other triage algorithms? You can see that it performed quite well in sensitivity and specificity. But the most important part of this is that this does not require a ton of expertise, right? Because when you look at the sensitivity between experts and novices, and we're talking about novices, these are novices who have never, ever held a dermatoscope. So all they're doing is they're coming to learn dermoscopy, right? So the sensitivities actually were no different between experts and non-experts. Now you will notice that the specificity also didn't differ between the two, but that's it's not true. We did not allow the experts to exit the algorithm on purpose, right? So, for example, this is meant to have a high sensitivity with a sacrifice of specificity. Give you an example. Clear cell acanthoma. You see, a clear cell acanthoma, you will immediately recognize as a clear cell acanthoma because it has this string of pearls-like vessels, right? Ah, that's a clear cell acanthoma. However, in this algorithm, it would get biopsied, right? Because it's organized with those vessels, it's going to come off. As an expert, the algorithms never were intended for experts. Algorithms are intended for novices because experts know when to exit, right? So the specificity here in the true expert's hands would actually be higher because they would know when to exit. But in this, we did not allow them to exit. Even if they knew that it was a clear cell acanthoma, we said, no, you got to follow the algorithm, right? So that's sort of making the point of the expertise does bring something to the table beyond an algorithm. It brings to the table when do you leave the algorithm, right? But at least for now, so that you can go out today and start using dermoscopy, this would be the simplest form of dermoscopy you can use. TADA algorithm, if it's a subcare DF or angioma, forget about it. If it's disorganized, biopsy. If it's organized, then look for one of these structures. If it's present, you biopsy. If not, then you can monitor. With that, also want to tell you a little bit about the meetings that we hold. We go every summer to a different national park. Somebody once asked me, is my intention to go through every national park in the US? And I said, yes, that would be lovely, but I'd be 150 years old. So it's very unlikely that that'll happen, but we'll go to as many as we can. So these are the ones we've visited so far. So every summer, it's usually a family affair. It's 3 full days of dermoscopy, believe it or not, from 6:30 in the morning till 5, right? All day long dermoscopy, so you can see how much there is beyond what we just covered here. The next meeting is going to be in Shenandoah National Park, and so those are the dates that are here. If anybody is interested in learning more about dermoscopy, that's the one. The International Dermoscopy Society also has a meeting every 3 years. The next one will be in 2021 in Argentina. So those will be another very big dermoscopy meeting that's coming up that's overseas. And with that, I thank you for your attention. And if there's any questions, obviously I'll be here.